Bedside Tutorials in Critical Care with me, your host, Pat Nelligan. When is a lactic acidosis not a lactic acidosis? To solve this puzzle, we'll start with a clinical scenario. Matthew is a 56-year-old male who was brought into the ED by his family. He's been found in his bedroom. He's sleepy but arousable. His speech is slurred. He's a bit confused. He's groaning with apparent abdominal pain. He's tachypnic. His heart rate is 105 and his blood pressure is 90/60. His temperature is normal. His ECG is normal. And these are his labs. Pause the video for a moment to assess these. What do you think? Note the low PaCO2 and the low bicarbonate. This patient has a partially compensated acute metabolic acidosis. The base deficit is -20. There is a widened anion gap and the lactate is unmeasurably high. The first thing that you might be thinking about here is sepsis. And the most common cause of sepsis is, of course, respiratory tract infection, but his chest x-ray is relatively normal. So this, on the surface, is acute lactic acidosis, right? Lactic acidosis is typically considered type A or type B. Type A is usually a manifestation of anaerobic metabolism. That's where there's huge demand for oxygen with minimal supply. We see this in trauma. We see this with ischemic bowel. We see this with exercise if you've ever run the marathon. There's usually a low mixed venous oxygen saturation. The second type is seen where there is increased adrenaline or epinephrine in circulation. We see this in sepsis and critical illness. We see it in diabetic ketoacidosis and occasionally in idiosyncratic reactions to metformin. With respect to metabolic acidosis itself, this can really only be caused by 5 things, one of which keeps the anion gap normal. That's hyperchloremia. And there are 4 things that widen the anion gap in order of frequency: lactate or lactic acidosis, ketones or ketoacidosis, and acidosis caused by unmeasured anions. Now, the most common unmeasured anions are renal acid. So when a patient has acute kidney injury, there are all kinds of things that accumulate, such as byproducts of the Krebs cycle and acetate and all kinds of stuff that just causes a reduction in the pH and the base deficit. And we just bundle them all together and call them unmeasured anions. And occasionally, and very rarely, the patient may become water overloaded and develop a dilutional acidosis from osmotically active agents, and you only see this once in a blue moon. Here are the rest of his labs, and you'll note that his chloride is normal and his creatinine is modestly elevated. But if you scroll all the way down to the bottom of this picture, you'll see a significant anomaly. And that's the serum osmolality. Now, that was measured in this case, and the osmolality here is very high. It's 338 milliosmoles per kilogram. When you see a high serum osmolality, you must calculate out the osmol gap. And to do that, you need to know what the osmolarity is. And that's a very simple calculation. Osmolarity reflects the number of particles that you can count in blood per litre. That includes all of the electrolytes, the anions and the cations. That's a lot of bits and pieces to measure. But because all of the anions equals all of the cations, if you can just calculate the cations and double them, that's the sodium and the potassium, and double them, that gives you all of the electrolytes that are present. And then the other osmotically active products that we see in the plasma, the urea and the glucose, can be added. So the serum osmolarity per litre is twice the sodium plus the potassium plus the urea plus the glucose in millimoles per litre. And that works out here at 2 times 140 plus 5.9 plus 4.5 plus 10.1. And that gives us a serum osmolarity of 306.5. And that means there must be an osmol gap present. And the osmol gap is the measured osmolality minus the calculated osmolarity. And that's 338 milliosmoles per kilogram minus 306 milliosmoles per litre. And that gives us an osmol gap of 22 milliosmoles per kilogram. So what causes a widened osmol gap? The most common things are alcohols and toxins, particularly methanol, ethylene glycol, isopropyl alcohol, ethanol, glycerol, and paraldehyde. Most of these are poisonings. These are either taken deliberately or accidentally, but most of them are never supposed to be ingested with the exception of ethanol. The other causes are diabetic ketoacidosis. This patient had a normal blood glucose or relatively normal blood glucose. Hyperlactatemia, yeah, absolutely. He had a high lactate on the blood gas analysis, and acute kidney injury, hyperproteinemia, and hyperlipidemia. Now, Matthew's son arrives in the ICU and tells us that his father has a history of depression, and he found an empty bottle of antifreeze in the kitchen. That bottle was 3/4 full last week, so he thinks that his dad has consumed 500 mils of antifreeze. Antifreeze is a product that's used to prevent engines from freezing by lowering the freezing point to below -37 degrees Celsius. It usually contains ethylene glycol, that's C2H6O2. Sometimes it contains diethylene glycol. Diethylene glycol is used in cheaper products, but it's in there and you will come across it. The thing about ethylene glycol is that it's colorless, odorless, and slightly sweet tasting. Apparently it tastes quite pleasant. When we looked at the toxicology of Matthew, we found that his ethylene glycol levels were really high, as were his diethylene glycol levels. So Matthew had ethylene glycol poisoning. Some of you of a certain vintage will recall the Austrian wine scandal that erupted in 1985. In the 1970s and 1980s, cheap sweet wines were very popular, and most of them came from Austria and Germany. Now, sweet wines can also be a very high-end product, but a lot of the lower end were Liefraumilch type wines that were sold in very popular products in supermarkets. And Austrian wines were never quite as sweet as German wines, but they had a large volume production that was contracted to various supermarkets. But there was a problem in the early 80s in that the weather wasn't great and the wines didn't sweeten, and they didn't get quite sweet enough to satisfy the orders. And a number of wineries and a chemist conspired to adulter the wine with ethylene glycol to improve the sweetness and body of that wine. Subsequently, a lot of this wine was sold into the German market, where it was mixed with German wines, and quality control agents in Germany discovered the ethylene glycol. This became public knowledge, it caused an outcry, and it destroyed the Austrian wine industry for decades. It also had a very negative impact on the German wine industry, because those cheap German wines that were being sold to the UK and Ireland became toxic products. And these days it's still quite difficult to find German wines in supermarkets where I live. What happened to all the wine? Well, 27 million litres of wine in Germany were destroyed. That was 36 million bottles. Strangely, in Austria, the winter of 1986 was so bad that they started using the wine that was otherwise going to be thrown out as road antifreeze. Ethylene glycol adulteration is a problem worldwide. And as recently as 2022, there was a big scandal where cough syrups that were apparently made in India ended up killing 70 children in Gambia, and this is really a horrendous story that's worth reading if you're interested in this topic. Also, there was a whole group of soldiers in a US military base who drank an unlabeled bottled liquid that they thought was vodka, and they became poisoned from it, and the mortality rate is extremely high from this particular product. Ethylene glycol, as I've mentioned, it's colorless, odorless, and slightly sweet tasting, so it could be easily mixed up with, for example, vodka. But when it's ingested into the body, it travels to the liver and it's metabolized in two major pathways that normally metabolize ethanol, the alcohol dehydrogenase pathway and the aldehyde dehydrogenase pathway. Let's just have a quick look at what happens with ethanol. So ethanol is ingested in the body. It's in wine, it's in spirits, it's in all kinds of stuff. And when it goes into the liver, alcohol dehydrogenase breaks it down to acetaldehyde. And then subsequently, aldehyde dehydrogenase breaks it down to acetate. And acetate then is transferred to the mitochondria, where it's delivered via monocarboxylate transporters into the inside of the cell and then utilized as part of acetyl coenzyme A. So it goes into the Krebs cycle and it's used for energy. And that's why alcoholics can subsist on alcohol for a large proportion of their calories because it directly feeds acetyl coenzyme A. Ethylene glycol is also partially metabolized by alcohol dehydrogenase to glycoaldehyde. And glycoaldehyde is broken down by aldehyde dehydrogenase to glycolate and then glycoxylate and subsequently to oxalate and glycine. These are all really toxic chemicals. So the oxalate has a pKa of 4.2, so it will cause a metabolic acidosis associated with unmeasured anions. The anion gap will widen, and this has a cytotoxic effect on the heart, the brain, and the kidneys. So the oxalate itself is a toxic chemical. Oxalate chelates with calcium to produce a calcium oxalate salt or crystals, and they precipitate out in the renal tubules and cause acute kidney injury. So with ethylene glycol poisoning, there are a number of stages of disease. The first stage is acute neurological and gastrointestinal anomalies that are seen between 0 and 12 hours post-ingestion. The patient looks like they're drunk. They get confusion, ataxia, slurred speech, dizziness, and sometimes even become comatose. They may develop nausea and vomiting or abdominal pain like Matthew, and sometimes this looks like they have an abdominal problem going on. And a lot of this is due to CNS depression associated with the toxic effects, the direct toxic effects of ethylene glycol and its metabolites, as well as ethanol-like effects. Between 12 and 24 hours after ingestion, there's a cardiopulmonary phase. Patient develops tachycardia, hypertension, and acute respiratory distress, some of which is associated with acute metabolic acidosis. And there are a bunch of different electrolyte abnormalities, particularly hypocalcemia. A lot of this is associated with the glycolate and oxalate levels, those unmeasured anions. The hypocalcemia is because of the oxalate binding with calcium. Then, of course, there is the high risk of acute kidney injury. So between 24 and 72 hours, the kidneys will fail as a result of all these calcium oxalate crystals in the renal tubules. The patient's acidosis gets worse. This causes all kinds of cardiovascular anomalies. The potassium goes up. The patient becomes uremic and oliguric and eventually anuric. So how do we identify ethylene glycol poisoning? Well, it's difficult. Initially, the patient presents with altered mental status. They'll have a metabolic acidosis, early acute kidney injury. The metabolic acidosis is associated with the widening of the anion gap because of unmeasured and unmeasurable anions. There is an osmolality gap, and that really clinches the diagnosis. That's why when we get a patient in with a severe acidosis and the patient, for example, doesn't look as sick as they should for the level of acidosis, I always ask for a serum osmolality. The patient will have hyperkalemia and hypocalcemia. The QT interval might be prolonged in the ECG, and if the urine is examined, there will be calcium oxalate crystals. But to clinch the diagnosis, you have to measure ethylene and diethylene glycol levels, and that can be done in most toxicology labs. What of the lactic acidosis? You recall this patient presented with a plasma lactate of more than 20 millimoles per litre. Suffice to say that there actually isn't a lactic acidosis present, and even if there was, the magnitude of that lactic acidosis is grossly overstated because this is a spurious result generated by a problem with a specific test. Lactate and glycolate look quite similar. And when the blood gas machine measures lactate, it uses a test known as the lactate oxidase test. This works through an enzymatic reaction in which lactate is oxidized by the enzyme lactate oxidase to produce pyruvate and hydrogen peroxide. In most blood gas machines, hydrogen peroxide reacts with a chromogen in the presence of peroxidase, and then a colored product is produced. The intensity of the color is used to quantify the plasma lactate level. So far, so straightforward. The problem is that glycolate also reacts with lactate oxidase to generate hydrogen peroxide, and that may be quantified by the blood gas machine as lactate. Hence, in ethylene glycol poisoning, the lactate level looks high because what you're measuring is glycolate, not lactate. So, in blood gas analyzers, lactate and glycolate are structurally similar, and if the blood gas analyzer uses the L-lactate oxidase test to measure lactate, then glycolate may be misidentified as lactate. Now, if the real lactate is measured in the laboratory, the difference, the lactate gap, can be used to follow the clearance of glycolate, because we can see what the real lactate is and then follow the spurious lactate measurement all the way down until the two coalesce. Managing ethylene glycol poisoning. As usual, when you have a patient who is acutely critically ill, you follow the standard protocol of putting in an IV line and looking after the airway, breathing, circulation, etc. This patient will need IV access and generous fluid resuscitation with balanced fluid. Sodium bicarbonate may be used to stabilize the metabolic acidosis. The value is unproven, but many doctors will give it. Calcium gluconate may also be given to replace the chelated calcium. Early consideration should be given to kidney replacement therapy, either continuous kidney replacement therapy or intermittent hemodialysis. But the big treatment here is an antidote, and the antidote is famotidine. Famotidine is a competitive inhibitor of alcohol dehydrogenase, and it prevents the conversion of ethylene glycol to its toxic metabolites, that's glycolic and oxalic acid. It's very safe and easy to administer intravenously, and if you suspect ethylene glycol poisoning, just go ahead and give it while you're waiting for the lab results, the toxicology results to come back, because it will not harm the patient. The typical initial dose is 15 milligrams per kilogram, followed by 10 milligrams per kilo every 12 hours, and it's continued until the ethylene glycol levels are lower than 25 milligrams per deciliter, or the lactate, the spurious lactate on the blood gas machine, is lower than 2 millimoles per liter, and the anion gap is normalized. And this is how famotidine works. It blocks that alcohol dehydrogenase enzyme and therefore stops the production of all the toxic metabolites. And then gradually ethylene glycol is excreted unchanged in the urine. Usually the duration of famotidine therapy is 24 to 48 hours, depending on renal clearance. If intermittent hemodialysis or continuous kidney replacement therapy is instituted, there is no change in the dosing regimen. It may shorten the duration of therapy by clearing all the junk out, but has no impact on famotidine. The famotidine pharmacokinetics are unchanged, so it doesn't dialyze. This patient's acidosis gradually improved over 48 hours. You can see here that he started off with a pretty impressive base deficit and then it gradually reduced. But simultaneously, his renal function deteriorated quite substantially. You can see he went from a creatinine of 112 all the way up to a creatinine of 530. And so he required initially continuous kidney replacement therapy, that's CVVHDF, and then subsequently intermittent hemodialysis. Everything settled down by about day 8 after ingestion. By day 3, the ethylene and diethylene glycol levels were down below that critical 25 milligrams per deciliter. So Matthew's condition stabilized fairly quickly. He had no problems afterwards. He was able to give me permission to use his data in this particular presentation. And he did require hemodialysis up to day 7. He was seen by liaison psychiatry and deemed low risk. And over the next month or so, his renal function recovered completely. Let's review this tutorial. Alcohol poisoning should be considered in any patient with acute metabolic acidosis, a widened anion gap, and confusion with or without acute kidney injury. In any of these situations, you should measure the serum osmolality. Be careful if the magnitude of lactic acidosis is out of proportion to the degree of illness. It might be spurious. In any situation where the lactate is higher than you would expect, you should consider, for example, ethylene glycol poisoning or a problem with metformin. As soon as ethylene glycol poisoning is considered, a famotidine infusion should be administered. If you cannot get your hands on famotidine, and every hospital that has an emergency department should have this drug, then you can give the patient alcohol, because remember, ethanol will also compete with ethylene glycol for access to alcohol dehydrogenase and will give the kidneys time to clear the ethylene glycol. I hope you're enjoying these tutorials. If you are, please subscribe on YouTube, leave me some likes and some comments, introduce me to some of your colleagues or friends, and follow my blog at ccmtutorials.org.